Okay. Well, go ahead. Can everybody hear me okay? Is this working? Is it working? Okay. Okay. I can't hear myself, so we got a lot to talk about this afternoon, so I'll go ahead and get started. I want to welcome everybody to Chicago. I'm Robert Kaufman from Texas Tech University. I'm actually a reproductive endocrinologist and a statistician, but when you become chairman of the department, you revert back to cleaning floors and labor and delivery and a few other things. So making schedules and things that probably a third grader could do. So I've always been fascinated with cardiac disease in pregnancy. I've actually been absolutely fascinated with hypertension in pregnancy, and they've been nice enough to let me talk about that the next hour. And so I know why I did a fellowship. So because I really like doing statistics more than anything, but I had to talk to people every once in a while. So we'll go ahead and get started today, and we're going to go through a lot of information this first hour on cardiac and some endocrine disorders. In all the lectures I'm going to give today and tomorrow, I put a lot of tables in that I actually devised myself, and those are for self-study. We won't have time to go through those tables, but I've tried to take some of these very complex tables we always see in journals and try to make them simple for self-study. So please, I put probably more material in this for self-study than I could ever go through, but we'll have time for questions, and I'll be around for the next couple of days as well too. You also have study questions at the end of the lectures, and there should be a key somewhere in your handouts to the answers to those. And but let's go ahead and get started. And here are some of the abbreviations. You know, cardiologists are next to endocrinologists of loving abbreviations, but these are pretty common standard abbreviations. Let's talk about pregnancy physiology. I think most of us know that blood volume goes up by 50% during pregnancy, and that's why, of course, our gravidas can lose 500 cc's of vaginal delivery and just get up and walk out. If you or I did that, we'd probably be a little faint or tachycardic by the time we lost 500 cc's of blood. The plasma volume goes up about 50%, and the blood volume a little bit less, maybe about 30%. And most of us know that H&H falls during pregnancy due to hemodilution. Preeclampsia, in fact, is associated with hemoconcentration. In fact, the blood volume may go back to the non-pregnant volume. So as many of you know that preeclamptics don't always tolerate blood loss quite as nicely as those who don't have hypertensive disorders of pregnancy. The cardiac output starts going up very early in pregnancy. In fact, it may go up by 50%. So when we start talking about cardiac anomalies in the mom, they're not going to be able to handle this huge increase in cardiac output. Don't die with this one here, but this is what we remember from physiology in medical school, that cardiac output is the stroke volume versus the heart rate. And stroke volume goes up tremendously, about 30-35% during pregnancy, and that's due to left ventricular dilatation. The afterload is peripheral vascular resistance. Blood pressure is a nice way of saying that as well. That's a good surrogate marker, where the preload might be the blood volume. So think about blood volume as a preload, and blood pressure being a surrogate marker for the afterload. And I've talked about this already. Twins are even more dynamic. Their blood volume goes up even more, and their cardiac output goes up another 20% over the singleton pregnancies. Well, it even gets more dramatic. And why do some people not tolerate labor very well with cardiac issues? Because the blood volume at pushing goes up about 50%, the cardiac output goes up 50% in labor. And every time the uterus contracts, it has this autotransfusion phenomena where the blood volume will go up by about 300 to 500 cc's. This also explains why this acute blood loss of 500 to 1,000 cc's with vaginal delivery versus cesarean section is so tolerated so well by pregnant women that uterus contracts and presto changeo, there's another 500 cc's into circulation. We hear about this putting people on their left side all the time. This is going to increase the blood flow back to the uterus. That's going to increase the preload, and it does help decrease the heart rate and increases the cardiac output as well. finally, postpartum, again, that autotransfusion phenomenon occurs and you have a rapid increase in the total blood volume. And he had decompression of the vena cava as well too. And it takes about 3 months postpartum for the blood volume to go back to normal. So that will eventually occur. What about EKG changes? It's amazing sometimes how these little machines will misread EKGs. Be aware that you'll often see some changes. You'll see left axis deviation. You'll see again in V4, V5, and V6. You see these big peaks over here, but you may also see flattening or inversion of the T waves in lead 3 or the anterior leads in V1, 2, 3. So the EKG machine may read these as non-specific changes. We had one in labor and delivery the other day with some flipped T waves, and in fact, you try to call that myocardial ischemia. So you got to be careful about those machines sometimes. Got to be careful about radiologists as well too, but that's another issue we'll talk about extensively. So did you know that 30% of radiology reads are probably wrong? So I tell my residents all the time, you can disagree with the radiologist every day you want to, and you might well be right. So this is the New York Heart classification of cardiac, and also the Canadian. They're almost identical. I think most of us remember this from medical school, where class 1 is no impact. Class 2 is, they do well at rest, but they really go out and walk around the block a few times and might get significantly short of breath. That might involve some of us in here too, but I think we're still really ones. 3 is marked limitation, and class 4 are those who really cannot do much at all. They're pretty much bedridden in that, and we'll talk more about it in just a moment. Why is this whole issue of cardiac disease so important? Is that more and more women who are once told that they should not get pregnant are now getting pregnant. And that's a dilemma for you and us, or for you and me rather. And these babies are now living, and here's some of the things that we're now dealing with in labor and delivery units around the country. You can also see the issue of cardiac issues in pregnancy is going up as well too. What is the workup? What should we do when somebody walks in and said, I had a valve replacement, or I had a stenotomy, and maybe a mitral valve dilated or something like that? These are the basic things you want to do early in pregnancy. One is certainly get an EKG. An echocardiogram is always a good idea to get a baseline. A BNP, a B-natriuretic peptide. Now this is a problem because these go up in pregnancy. In fact, most of the time when you check this in the 3rd trimester, it's going to be over 100. What is our local internist going to say? They're in failure. He said, no, she's pregnant. So again, we as OB-GYNs need to know what normal values for pregnancy are. And this is an issue. I had one of these issues the other day, and somebody had acute fatty liver pregnancy where her level came back 300, and they said, I can't believe she's breathing so easy. They said, because she's not in failure. She's in everything else, but she's not in failure yet. But you might want to get cardiac consultation, and again, if need be, an MFM consultation as well. This is one scoring system I think is particularly good to see if those people with cardiac issues can be managed in a community hospital, or should they be managed in a referral center. You can get 1 point for each one of these issues here. And again, that's pretty easy to do self-study. And again, if you have none of these issues, these cardiac patients probably can deliver at a community hospital. If the score is 1 or more, you can see the chance of having a stroke, an arrhythmia, or even congestive heart failure goes up significantly. So again, it's a nice thing for you and me to be able to evaluate these people in the 1st trimester and try to get a pretty good idea whether or not this is going to be trouble or not during pregnancy. This is again for self-study. It's just some of the cardiac anatomy. And so again, what are the low-risk conditions? 31 is aortic stenosis, where the ejection fracture is good. Generally, aortic stenosis and mitral stenosis are the 2 lesions which are going to present a lot of problem to us in labor and delivery. But again, if their ejection fraction early in pregnancy is pretty good, then they may well do well down the line. Regurgitative lesions are usually fine. Mitral valve prolapse, again, is usually a fairly benign lesion. Mitral stenosis, if it's a mild mitral stenosis, they're probably going to do well, greater than 2 centimeters cube, or squared rather. And again, you can get that report very nicely off an echocardiogram. And finally, pulmonary valve stenosis. These are the ones which are going to cause trouble, and I would get rid of these to a referral center with some of a cardiologist who knows about these diseases fairly quickly. And again, you see the stenotic lesions. One is aortic stenosis less than 1.5 centimeters. Another one is mitral stenosis less than 2 centimeters. Again, most of these have been treated before they got pregnant anyway, so we're not going to run into these. These we might every once in a while. Again, left ejection fraction less than 40%. Say they've had peripartum cardiomyopathy in the past and they have an ejection fraction which is that low. Probably not one for the community hospitals. You can see the rest of these, and certainly Eisenmenger's physiology as well that we'll talk about in just a moment. This is another classification. I doubt this would ever show up in a test, but you might see some journals and some review articles in our own OB-GYN journals talk about the World Health Organization classification. Well, here's some general considerations for the cardiac patient who is pregnant. We need to team up with our cardiology colleagues, and not everybody has to go to bed rest. I remember as a resident at Parkland years ago, we used to put all the preeclamptics at bed rest, and what happened? They started getting pulmonary emboli, so we stopped that after a few years. Genetic counseling, if indicated, certainly a fetal echocardiogram. Many of these cardiac lesions that moms have also have a genetic component, a polygenetic and perhaps an environmental component. So fetal echocardiography is indicated. Certainly fetal surveillance and anesthesia consult in labor and delivery. Let's talk about valvular disease. We all know that everybody has an ejection murmur. I mean, the high flow during pregnancy causes this systolic murmur. But the diastolic murmurs, particularly mitral stenosis, are the ones that we need to be most concerned about. And what you'll find with mitral stenosis here is you're going to have left atrial enlargement, and you might also have right ventricular enlargement. And they may also have pulmonary artery hypertension as well. By the way, the definition of pulmonary hypertension is the pulmonary artery pressure is 75% of the peripheral pressure. So, and then there's a slide that goes over that in just a moment. What is the treatment for those? These people don't do well with tachycardia. So if they start, getting a little short of breath and tachycardic, it's time to bring the beta blockers on board. That can be labetalol that most of us are familiar with. It can be metoprolol, esmolol, it can really be any of those that have beta-1 activity. Diuretics and digoxin as well too. Balloon valvotomy can be considered during pregnancy, but most of these women have already undergone valvotomy before pregnancy. Mitral regurg is very common. Again, that high volume, that increase in 50% in later pregnancy will cause these very common systolic flow murmurs. They tend to be very benign. But do be aware that with a huge atrial enlargement, they may go into atrial fib. Aortic regurg is also well tolerated during pregnancy, and again, the reason for that is that afterload. It falls. The blood pressure falls in the second trimester, and that helps those with aortic regurg. Tricuspid regurg is also well tolerated. This is a bad player, usually congenital, usually identified in childhood, and again, most of those will be caught, but these people typically develop shortness of breath, and they may develop sudden syncope as well. And they're going to have left ventricular hypertrophy on echocardiogram. This is Eisenmenger's, and I happened to be on a few months ago. We had somebody come in, and she died from this. This is somebody from Mexico that we have a lot of, and of course in Texas. Had no prenatal care, came into the ER with florid pulmonary edema. We took her for a stat cesarean section. She died 12 hours later, and I'll show you her echo we got postpartum in just a moment. This is a bad player. These people should not get pregnant. These are people that have left to right shunt due to pulmonary hypertension, and they do not do well in pregnancy. In fact, ethically, if somebody has Eisenmenger's physiology or a history of that, they should be encouraged to terminate the pregnancy with that. And